So it was called congestive heart failure because there was pulmonary congestion. So if there's pulmonary congestion, so what that would mean is that there's backup of blood flow into the lungs. And there's backup of blood flow into the lungs, then you get congestion. So that can happen for one of two reasons. One is A, you don't have egress of blood from the lungs, and therefore that's what we call an ineffective pump, and that's what we call systolic heart failure. And that's actually exceedingly rare in pediatrics because having a heart dysfunction can happen. We'll talk about this a little bit later in a very specific context. But the vast majority of congestive heart failure in children is going to be what's called the inefficient pump. And this is just my terminology of how I do this. And so I tend to be a lumper when it comes to physiology, as Dr. Stallworth would call lumpers and splitters. And so I tend to be a lumper. I tend to try to take the physiology of one thing and how the body responds to it and extrapolate it to everything else. Okay. So the next part of it was actually the part about talking about the inefficient pump. And I was actually going to go to the draw you guys some examples, but I think maybe we can talk them through here. So the first example is what we call left to right shunts, right? So since there's only really two that cause congestive heart failure in children, right? And I can talk to you about that without having to go through this. So think of one as being a VSD, and that's going to be the most common inefficient pump. So with a large VSD, what you're getting is that the left side, remember that the way I teach you guys is right-sided pressures are low, left-sided pressures are high. So if it's a VSD, the blood is always going to go from left ventricle to right ventricle. So, and it's never cyanotic, okay? It's always going to be left to right. It's always going to be left to right. And so that's going to be the VSD example. The PDA example, that's the patent ductus arteriosus, that's going to be left to right at the arterial level. So that means that the pressure in the aorta is higher in systole and the pressure is higher also in diastole. So you get a continuous murmur of a PDA. So left to right shunt both in systole and diastole. Now, notice I didn't put things like ASDs and things like that on there because ASDs do not cause congestive heart failure in the sense of they cause congestion, not congestive heart failure. And the reason is because it's a low pressure setup. And so ASDs tend to be much more, and that's more insidious and indolent and long lasting before you get symptoms. But things like left to right shunts in VSDs and PDAs are much more common and happen and show up much sooner. So what's the first signs of congestive heart failure? So when we think about congestive heart failure, think about like a VSD. You have a big hole in the chamber between the left ventricle and the right ventricle. So what happens is that since your pulmonary vascular resistance is much, much lower than your systemic vascular resistance, blood is going to go preferentially into the lungs. It's going to go from left ventricle to right ventricle to the pulmonary artery, to the pulmonary circuit, into the lungs. And so therefore, if you imagine the lungs being like sponges, and a sponge, as you add more water to it, as you add more liquid to it, becomes heavier. So that's exactly what happens to the lungs. The lungs are air, or from the alveoli become, the entire pulmonary vascular bed becomes congested, and therefore the alveoli become less efficient. So the first sign of a large left to right shunt and congestive heart, what we call congestive heart failure, would be tachypnea, right? So tachypnea is the first thing that you'll see in a child. Now, so what is that? So tachypnea then leads to the other thing. So of course, if you have tachypnea, you have increased metabolic demands, you get the retractions, you get the tachycardia, and eventually you get the failure to thrive. And so think about a large left to right shunt, the most common ones you're going to see. And so how that relates to swelling is you're going to see congestion, and depending on the size of the VSD and the unmitigated congestive heart failure that you have, you get more and more swelling, you get hepatomegaly, you can get congestion. And so congestion, typically it doesn't give you swelling, like leg swelling and things like that you would see in the adult world. And the reason is because it's an inefficient pump rather than ineffective pump. And of course, with physical examination, you're going to see cachexia, active precordium, and of course hepatomegaly, and the plus or the minus the murmur. The reason I say plus or minus because oftentimes you don't have a murmur with this, and that's because it's a very large defect. For you to get a heart murmur, you have to have some changes in pressures. You guys stop me with any
We're going
questions.
to the cache.
I'm sorry? Pardon? Oh, okay. Can you hear me? I'm sorry. Okay. All right, I'll keep going because I heard somebody hasn't muted their microphone. I don't hear anything, but anyway. All right, so that's what congestive heart failure means. And so we talk about congestive heart failure, you know, the typical scenario is going to be a 6-week-old or
Dr. Rao,
yes, ma'am.
Sorry to interrupt. Could you just clarify what you mean about an inefficient versus an ineffective pump?
Right. So inefficient would just means that there's an intracardiac shunt, but the ventricular function is normal. Okay. And ineffective means that the heart's not pumping well. Does that make sense? So if you think about like when you did your adult rotations back in medical school, if you had an ineffective pump, it's usually because the heart wasn't functioning well. It wasn't squeezing well. In kids, and I have some echo images to show you the difference. So in kids, what you're going to get is you're going to get a with large intracardiac shunts, you're going to get an inefficient pump, but it pumps well. The heart is functioning well, but it's the systolic function is normal, but it's inefficient in the sense that there's going to be a large volume of blood that's circulating within the lungs. Does that make sense?
Yes, sir. Thank you.
Okay. So what that means in the context of the next sort of scenario. So congestive heart failure is basically there's no problem with heart function. That's what I mean by an inefficient pump. There's no heart dysfunction. So it's just a hole in the heart, but the heart's pumping well. Okay. So in the context of what that means for us. So for example, if you have, this is what we mean by an ineffective pump. So this is an example of a normal heart on the left. And then you see that there's good contract. So to get you an orientation here, anterior is up here, posterior is down here, the feet are over here, and the head's over here in this scenario. So this is the context where you see that this is the left ventricle that I'm outlining here. And so the left ventricle comes together. You can actually see the thickening of the heart muscle, and therefore the heart function is normal, but contrast that to here, where you have an inefficient pump. So the heart's not squeezing. You don't see the thickness of the heart muscle. You don't see it coming together in systole. And so, and this is sort of the barrel view of the left ventricle. And so this is another view of the left ventricle being dilated here. So the difference is that, so this is an ineffective pump on the right, and this is a normal pump. And oftentimes in what you're going to see in a VSD is you're going to see this scenario with a nice strong with tachycardia is really the only thing we might see on the echocardiogram, but the pump itself is actually very effective. And so one of the measurements that we do as cardiologists that you'll see from us is you'll see us measure something called the ejection fraction, right? So what the ejection fraction, it's actually it's a construct that all we do is, and it's very simple, it's sort of terminology is very simple to understand, is that we just measure something in systole and diastole. Okay, so whatever distance this is in diastole, it's going to be larger. And then and then when you have systole, this dimension is going to be shorter. So the difference between the two as a percentage, we call fractional shortening. Okay, that's oftentimes you'll see us refer to that on echo reports as fractional shortening. Then all we do is we extrapolate this two-dimensional image to the shape of a ventricle, and then that gives you ejection fraction. So this single number here is then extrapolated to ejection fraction. So anything above 60% we consider normal. So talk about things like, if we're talking about like for example, a ventricle like this, its fractional shortening will be very, very low. So if we extrapolate that, this ejection fraction might be about 25% roughly, based on what I'm seeing in this picture. So this is a patient with this is a 12-year-old who presented with congestion in the lungs. Actually, this is in the ER a few weeks ago. And this is a patient who had dilated cardiomyopathy. And so they present with dilated cardiomyopathy. And so the scenario then becomes very different as opposed to where you're talking about whether inefficient versus ineffective. Does that make sense? Okay. So we're talking about inefficient pumps. So you're talking about inefficient pump being sort of just really the only ones we're going to see is going to be the VSD and the PDA. And then you're going to see rare things like truncus arteriosus and stuff like that. So in your board preparations, the way to think about this is so the scenario will be like this. They'll say 2-month-old presents with tachypnea, and they'll give you a heart rate that's elevated. they'll give you hepatomegaly. And they'll give you, that's about it. And then they might say, what is the, and the question stem is not going to be as simple as this is a VSD. The question stem might be like, why didn't this patient show up with symptoms earlier or something like that? And so, of course, the answer is the physiology doesn't allow that to happen, because it's not until the pulmonary vascular resistance falls over the first 6 to 8 weeks do you start seeing evidence of VSDs, clinical evidence of VSDs and PDAs. And so that will be the scenario. So pay very close attention to the age, because if it's a child, say in the 2 to 3 month age range, you're talking more about inefficient pumps, so VSDs and PDAs commonly. They're rare. There are other things too that are also things like the T's of congenital heart disease, and the most common one that will show up with inefficient pump is something called truncus arteriosus. But to answer that question, they'll have to give you another stem about things like dysmorphic features, calcium metabolism, and sort of give you some signs that this patient has DeGeorge syndrome, and therefore truncus arteriosus would be the thing, is the kind of the pathway that they're leading you down. So, and so the scenario of the ineffective pump then becomes a little bit, it'll come as a different scenario. So for this pump to become ineffective, you really have to have one of two things. You have to have downstream obstruction, so we call obstructive left-sided lesions. And so, the most common being aortic stenosis. So if you think about heart ejecting from the left ventricle out the aorta, if there's a problem with the aortic valve, significant stenosis, then the left ventricle cannot eject, so the left ventricle can fail. And so we call that an obstructive left-sided lesion. So that's a sign of significant enough aortic stenosis to give you cardiac compromise. And so, excuse me. So obstructive left-sided lesions, for all intents and purposes, are these three. And of course, the first two are the ones that are most likely to either pass the initial CCHD screen, or they may be one, because oftentimes the hypoclast, we've already have a prenatal diagnosis. So the ones that can surprise us in the newborn nursery are going to be things like aortic stenosis, coarctation of the aorta, because if you think about it, it's not really until postnatal life where you actually get the left ventricle to do most of the work. So if the left ventricle is suddenly, once the baby's separated from the mother, fetal circulation transitions into adult circulation and postnatal circulation. And that's why things like aortic stenosis and coarctation show up later, within the first, as the PDA closes, so within the first week or so of life. So when we talk about the ineffective pump, we're talking about aortic stenosis and coarctation typically. Those are the two most common ones. Now, the other category of ineffective pumps are things like acquired heart disease. So specifically, we're going to talk about myocarditis and also Kawasaki disease with coronary involvement. And that, again, it has to do with, these are things that happen further down the line. So the myocarditis typically is going to be a teenager presentation in your question stem. So the question stem might be things like a 15-year-old had a viral infection 6 weeks ago, now presents with congestion and cough. Do the X-ray, and the X-ray shows very similar to what we see here with pulmonary congestion and cardiomegaly, and this is what we're seeing on this X-ray. So this looks very similar to a child with a big VSD. And so when you see that scenario, then what you're thinking, what they're leading you down towards is myocarditis. And so, and of course, the Kawasaki differentiators are going to be a little bit different in terms of how they present. So in terms of obstructive left-sided lesions, you don't get the same swelling and the congestive heart failure unless you get to a situation of what we call critical stenosis. So when you have critical aortic stenosis, you can have aortic stenosis without it being critical. Well, the word critical means is that you have failure of the left ventricle. So if you have critical aortic stenosis, that causes LV failure. If you have critical coarctation, that causes LV failure. And of course, if you have absence of the left ventricle altogether, we call it a hypoplastic left heart syndrome. So the scenario that you might get in a obstructive left-sided lesion with congestive heart failure, i.e., and how it pertains to peripheral edema, would be things like would be critical aortic stenosis with LV failure, pulmonary congestion, and oftentimes the X-ray looks identical. to all the other ones, the one I just showed you with congestive heart failure. It shows you a large heart with increased pulmonary vascular markings. And so if you see a large heart with increased pulmonary vascular markings, in your mind, you kind of have to put it together with, is this a large left to right shunt, or is this a failing heart? And so those are the two descriptors. And so if it's a large left to right shunt, you'd call it an ineffective pump. If it's an inefficient pump. And if it's a large heart because of a failing heart, you'd call that an ineffective pump. And so the terminology is the X-ray looking can look exactly the same. So there have to be something to distinguish between the two when you see this on a question stem. Now, other things that are super important and that to think about is sort of the long-term things of sort of long-term progression of any kind of left-sided disease. When you think about it, is whether or not they have a cardiomyopathy. So myocarditis is the one thing that should also be in your differential when you see a large heart and increased pulmonary vascular markings and swelling. And so, there's a million causes for congestive heart failure, myocarditis, but here are the things that are going to be test-related kind of things. So viral infections, typically it's going to be Coxsackie, parvo, influenza, adeno are the big players, and Coxsackie B is the one that often comes up in board examination. And then in terms of what we're seeing sort of clinically nowadays, is we are seeing COVID-19 as being a cause of myocarditis. Now, fortunately, we haven't seen any lasting myocarditis in these patients. We've seen either very, very short-lived myocarditis. Now we're starting to see this is where the MIS-C kind of stuff comes in, and we're seeing some evidence of heart dysfunction in patients that have had either recent COVID infection or even had COVID infection in the past. Other things that'll come up more rare are going to be this question stems are going to be things like bacterial causes for infectious myocarditis and Lyme disease. So the typical story is going to be sort of they're leading you down that pathway. Rocky Mountain spotted fever, believe it or not, it can actually happen, not even in the Rocky Mountains, it can happen here. And this is an interesting one, trypanosome, and I included this in here because we do have a large percentage as we're seeing a lot of patients from Central America. So we're seeing a lot of Hondurans and Guatemalans, and trypanosoma heart disease is extremely endemic in these areas. And this gives you a chronic. This is the Chagas disease heart, and so this is the one that can actually show up as a cardiomyopathy secondary to infiltration of these trypanosoma parasites within the myocardium. And so don't rule this out as a possibility. And of course, the treatment's going to be very similar, or treatment of heart failure is similar all around. Immunologic things, fortunately, these are quite rare. These are going to be in older children, sort of in the teenage years, are going to be the lupus, the rheumatoid arthritis, and the scleroderma. And fortunately, these are all the anthracycline drug-related ones. These are patients that have received chemotherapeutic agents, and these are the daunorubicins and the doxorubicins. And in those kids that have received it, it tends to be the heart function tends to be dose dependent. So that's why knowing the child who has ALL that responds to initial chemotherapy, the 6-year-old is very different than the 15-year-old who has AML and has recurrent bouts of AML and needs multiple therapeutic agents over time. That becomes a very different scenario. And of course, the other causes for the cardiomyopathy and the swelling, congestive heart failure, are going to be inborn errors of metabolism and muscular dystrophies. But muscular dystrophies, these tend to be sort of, and these patients typically don't show their cardiomyopathies until late teenage years, early 20s. Now, the most common inborn errors of metabolism that we're seeing, these are not the glycogen storage diseases, because that gives you hypertrophic cardiomyopathy. What I'm talking about here, these are the rare things. These are what they call like the carnitine deficiencies, where carnitine deficiency can give you a dilated cardiomyopathy. And so, so your first choice of a patient, like let's say a patient, a 2-month-old who presents with congestive heart failure, your first choice is going to be VSD if it fits the scenario of tachypnea and tachycardia. But assuming that that's normal, and let's say the physical exam doesn't show a VSD or the echocardiogram doesn't show VSD, then you're going down this pathway. Okay, and so you kind of have, these are of course much less common. Okay, So I'm going to spend a little bit more time on Kawasaki and how that's related to cardiomyopathy and the congestive heart failure. So you guys know all this. This is the original paper from Kawasaki himself. And so back in 1967, so it's first described, of course, you have to have the fever for the 5 days, and this represents the fever curve, and this is actually in Japanese here. I think this says fever curve. But this represents the fever curve, and of course the bulbar conjunctiva of both eyes, the strawberry tongue, and the undefined rash here, and the edema of the heart. The heart is sort of like the hard edema in patients that have Kawasaki, and this one also can include erythema of the palm and desquamation. That's where you see the desquamation oftentimes in the hands and the feet, in the periungual areas, and also the cervical lymphadenopathy, the non-infectious cervical lymphadenopathy. And so why is this particularly problematic as far as cardiomyopathy is concerned in congestive heart failure? Is because untreated, about 25% of Kawasaki patients will go on to develop these scenarios. So what happens in Kawasaki is that essentially you get what's called a panangiitis. So it's a small and medium vessel arteritis that has a predilection, and of course it affects all the small and medium arteries in the body, but the one that's most worrisome obviously is the coronary implications. And so when we talk about that, you get the, and oftentimes you'll see this in the way that we report this as being patients with coronary vascular. We can actually see this panangiitis. What we see is on the echo, we'll see infiltration of the coronaries. The coronaries are actually very hard to see in a typical child, if you think about it. They're small vessels, only about 2 millimeters or so. And if we put our echo probe down on the child, and it's a 4 or 5 year old child, we should be struggling to see the coronaries. But when we see them right off the bat, what it usually means that they're echogenic and that we're able to see this inflammation. And so this inflammation then results in weakening of the intima of the coronary arteries, in which one of two things can happen. You can get intimal hypertrophy, then stenosis later on, or you can actually get clot formation and acute MI. And so the kids with Kawasaki can get myocardial infarction. And so that's really important to keep that in mind when you have a patient. And so typically it's going to be in sort of the acute and the subacute stages where you get the myocardial infarction, ischemia. But in the patients that have had coronary artery compromise, they can get late congestive heart failure. In fact, Kawasaki is the #1 cause for requirement for heart transplant in patients with in Japan. Japanese children is Kawasaki disease with coronary artery involvement. So to us, what that looks like is if you imagine the coronary, you have a left coronary, you have left anterior descending, and this is left, this is right, this is up, and this is down. So what you end up with here is that you end up with a scenario where the coronary is supposed to be nice and splayed out over the heart, but you get sort of these saccular aneurysms or fusiform aneurysms across the coronaries. And so because of this because of this sort of unfavorable hemodynamics of the system, you can get ischemia, you can get clots, you can get stenosis. And oftentimes these aneurysms don't go away. And in fact, they can actually get larger and larger to the point where the only way they heal is with calcifications, and you end up with a child with large coronary aneurysms, and you're just kind of limping them along till their heart function recovers, because downstream you may not be getting effective coronary perfusion. And so that's the reason how Kawasaki can present with congestive heart failure. Any questions so far, guys? Okay. I will take from your quietness that you understand about Kawasaki and what's going on here. So untreated Kawasaki, you have about a 25% chance of developing coronary artery aneurysm. Treated Kawasaki, it goes down to low single digits percentage of Kawasaki, and typically the ones that are going to be more likely to get coronary artery aneurysms are going to be the children who have atypical presentations of Kawasaki. So maybe fever and not all the major criteria and some of the minor criteria, which I didn't go through. But the take-home message is that if you look at the normal age range for kids with Kawasaki, it's the kids on the outer edges that typically will present with atypical Kawasaki. Those are the ones that are more likely to have coronary artery aneurysms. And that's probably not necessarily related to the how the disease affects them. I think it probably is related to delayed diagnosis, more likely than anything, because you don't think about a 1-year-old having Kawasaki. You certainly don't think about a 10-year-old having Kawasaki, but those are the age groups that typically end up with coronary artery issues because of that reason, because it's usually a late presentation, late diagnosis, not necessarily late presentation. And so that's a scenario with Kawasaki. So like all patients, when it comes to evaluating, whether or not a patient has congestive heart failure, what you're going to think about is what are you going to do about it, right? So, if you're evaluating a patient with CHF, which obviously the history is going to have to tell you that, but before notice I didn't even put down echocardiogram yet, right? So basically it's the history and the physical, right? That's going to tell you a lot about what's going on. Chest x-ray is super important. So think about that as being one of your first lines before you even call us for an echo. I didn't put echo because this is mostly for yours, and we can decide whether a child needs an echo or not. But chest x-ray is super important. EKG can be important, especially in the context of things like if you see a large heart on an x-ray and you don't know whether this child's in heart failure, then you might see, you'll certainly see something different with a dilated cardiomyopathy versus, say, a large VSD, right? As a large VSD, you'll get biventricular hypertrophy on the EKG and tachycardia. But if it's dilated cardiomyopathy, you might see ventricular enlargement. And if you don't have enough muscle mass because it's a dilated cardiomyopathy, you might see low voltages as well. You'll also see low voltages in patients that might, like a patient with Kawasaki, who may have a pericardial effusion, of course. That can certainly be the case of why you might see that. And the labs that are super important from my point of view, as far as congestive heart failure goes, is going to be BNP. Now, BNP is an interesting, it's, even though it's called, I put what it actually stands for, it's a brain natriuretic peptide, and it's very high, it's in high concentrations in the atrium. And so when the atrium is stretched, the BNP goes up. And so when you say, and the thing is, we don't look at norms for BNP. For example, we look at it patient to patient. For example, if a patient's BNP goes from, say, 50 to 10,000, then that's a very important consideration for congestive heart failure. Then if you have a patient who goes from, say, 50 to 60, it could be things like an effusion, or infusion, excuse me. Let's say you give IV fluids, and can you give me 1 second, guys? I'm giving a talk here. And so in patients that have atrial stretch, and oftentimes when you do your BNP before you give fluid boluses, you will see a bump up in BNP, but it's going to be, when you look at BNP bumps, look at it as it has to be orders of magnitude greater than what you see initially to know whether it's congestive heart failure. BNP is also a good tracker for chronic congestive heart failure, so we'll use that. So, and then of course for acute injury, it's going to be troponins, and these are going to be cardiac specific troponins. And this is very important in our MIS-C patients. As we're tracking their troponins every 8 hours, we're seeing significant evidence of cardiac injury. And a lot of times these are ongoing myocarditis where the troponins still continue to go up serially. And the CBC is helpful in case you have patients that are the hematocrit's low. Then of course you can get cardiomegaly on a chest X-ray. If you have a sickler and they're chronically anemic, that'll give you that'll give you the same symptoms, the same physical exam findings of a congestive heart failure. You might see cardiomegaly on the chest X-ray. You might see tachycardia on a physical examination. What you don't see is increased pulmonary vascular markings on the X-ray. So that's where the CBC is very helpful. So think about that. Of course, and the echocardiogram is always going to be helpful, and having a cardiologist lay hands is helpful too. And then the physical examination. So peripheral edema is even though it's listed on the thing on your syllabus for this, it's actually pretty rare, but you'll see more hepatomegaly. So that's the way to think about how this manifests itself, because the most common reasons you'll see this is in the context of patients who have cardiomyopathies and congestive heart failure. So how do we treat these? So of course, if it's a large left or right shunt, we'll correct the lesion, and that whether it's VSD, it'll be in the operating room. If it's PDA, it'll be in the cath lab. And same thing for whether or not you have corrected lesions and obstructive lesions, whether it's a coarctation, critical aortic stenosis, those are surgery or cath based. And then for the myocarditis, it's going to be a matter of treating them with diuretics, beta blockers, DAPT reducing agents. Those are the chronic therapies. In the acute stage, it'll be steroids, aspirin, reducing inflammation, and basically you're looking at it from a context of an acute myocardial injury that you want to prevent from being a chronic myocarditis. And so the rule of myocarditis is typically this. So a third of myocarditis, patients with myocarditis patients will get better, a third will stay the same, and a third will end up needing things like ventricular assist devices and transplants. I think that's kind of a little bit of a scenario. I think it's most likely probably like 60% will get better within 6 months, and another 30% will get better or stay mildly reduced for much longer, and then a smaller percentage end up with LVAD and transplant. Interestingly, what we're seeing a lot of nowadays, and you guys are actually taking care of these patients, you guys are taking care of a lot more myocarditis with this MIS-C population than I think, than I certainly did at your stage of the training. And we just don't see myocarditis as being very common before this pandemic, and this has become sort of on the radar for all of us. And there's a couple of you in the residency program that are working with me on some projects about cardiac implications for patients with COVID infection. So anyhow, so that's sort of the scenario that we have. So important. I didn't put a take-home slide at the end, which I usually do, but anyhow. Do you guys have? So I'm going to open this up to some questions about congestive heart failure, myocarditis. Any questions right now? Dalton, I see your name up here.
I'm here.
Yeah. Do you have any questions, Dalton? Since you just got off a cardiology.
Can you talk? I know it's not like a totally just with CHF, but can you talk about like kind of the return things that you do after MIS-C, just because it's so pertinent and we're seeing it all the time?
Yeah, it's so pertinent to our practice right now. That's true. So what we've been doing is that once these patients with MIS-C go home, if there's coronary involvement, so we've established that coronary involvement is going to be several things. It's going to be and it could be all things, obviously. So if there's an elevation in troponins and or BNP, so if there's any cardiac involvement, we've been calling these MIS-C patients because most MIS-C patients are not going to have cardiac involvement. So that automatically means that you get sort of the same treatment as of myocarditis, which is the serial cardiac enzymes, a baseline BNP, and then the echocardiogram upon presentation. And so when to order the echo. So when you guys see these patients that come in the middle of the night, one of the questions that came up the other night was a patient that you suspected had MIS-C or some version of this. And the troponin was elevated. And the questions I went through with the resident was whether or not you think this child is in heart failure, because they can certainly be in heart failure. So the questions we'll ask is, is the child in respiratory distress? Is the child having hypotension? If they're not, then the echocardiogram would certainly wait till the morning. It's a lot due to it adds cost to the system. If you have a thriving child, or actually if you have a hemodynamically stable child, you want to echo in the middle of the night. So we do that part of it, and they're going to get their steroids, they're going to get their aspirin, they're going to get their, and then they're going to go home. And then 2 weeks later, we do a coordinated visit with rheumatology. And at that time, we'll repeat the echocardiogram and the EKG. And then we'll also repeat the blood work. Specifically, from our point of view, we're going to look at the BNP, and the kids usually are not going to be discharged home until their troponins have normalized. That's the most of all the blood tests. That's the most sensitive and specific when it comes to ongoing cardiac injury. And so I'll have you guys do is just do the troponins. And sometimes if the troponin trend is going down significantly and stays down for a few cycles, we might send the kid home even though the troponin might be elevated. And so waiting for it to get totally normal sometimes is not very effective use of our time, because we can certainly get those as an outpatient too. And so we will repeat the troponin in 2 weeks, repeat the echocardiogram and the EKG. And then it's interesting, now that you have a patient, let's say you have a teenager who had this, now what do you do with them? So what we've been doing is we've been kind of going on the pathway of the myocarditis. And so when you hear about sudden cardiac death in the teenager, one of the causes is recent myocardial injury. And so recent myocarditis. And so what we've been doing is that 6 months after disease, we're going to get a cardiac MRI. And so it's not helpful to get it initially. And the reason is because you're going to see a lot of inflammation. We don't know and they're going to be exercise restricted anyway. So make sure you send these patients home with exercise restriction, these MIS-C patients. And if they're competitive athletes, they have to be competitively restricted. Obviously, it's very different if it's an 8-year-old with exercise restriction. You're not going to put them to bed rest. But if you have a child who's 12 and above who had MIS-C and who is a varsity JV player, that kind of level athlete, then they have to be restricted. And then around 6 months of age, we're going to reevaluate them, do a cardiac MRI, and then decide whether they have any ongoing myocardial injury and scarring from this infection. And if they don't, then we presumably clear them to continue sports. But if they do, we don't know yet because this disease has not been around long enough for us to know this. But if we're going to use the example of myocarditis, if we see any evidence of fibrosis in the myocardium, then we would do is restrict them almost or limit their sporting activities. We may restrict them from, instead of playing basketball and soccer, they may have to play, they play golf or baseball or something like that. So that's the scenario, Dalton, is how we're following these patients. So, and then there's a little overlap between the Kawasaki and the MIS-C patients, and it's because it's all the acute inflammatory markers, and so it's an ongoing inflammatory process. And I think we're seeing a lot of these patients. It appears to have some relapsing kind of phenomenon to it, and so that's why Dr. Dingle has been involved in a lot of these patients. Like we have a couple of patients now who actually had their MIS-C, we think back in November, and now they have things. And so whether or not they were missed or under recognized, and now we're having relapse of that with the elevation in troponins. Right? Does that answer your question, Dalton?
Yes, sir. Thank you.
All right. Very good.
Val,
Yes.
could you talk a little bit about fluid resuscitation in these patients? Because I feel like we always freak out when we see a heart kit and we don't want to be aggressive.
No. So that's a very good question. So it really depends on a couple of things. So if you see fluid resuscitation is only going to be a problem if you have cardiac dysfunction. So if you have dilated cardiomyopathy, if you have myocarditis with poor function, and so if you're uncertain of that, a chest X-ray is very helpful. So where you could potentially get into trouble is like the difference has to do with Starling mechanics, right? So if you have myocarditis with cardiomyopathy, you're kind of living on the right end of the Starling curve. And so since you're living on the right end of the Starling curve, then if you give more fluid, then you can fall off the curve and worsen the situation. Now, if you have a child with a VSD, you actually have good function. And so if you give too much fluid to a child with a VSD, all that happens is the child ends up with more pulmonary blood flow. And you can actually diurese that off. You can get that off. So it's less of a problem with the VSD than with a cardiomyopathy kit. So that's where the differentiation goes. And so my cautionary tale would be this is don't fluid resuscitate. Fluid resuscitate as you need to, obviously, to control shock, but look at the X-ray first before you decide to do that. And a really good sort of marker for this is acidosis, because a large VSD, even though you have a large heart and all that stuff, typically these kids are comfortably tachypnic and not terribly acidotic because they've had it for a long time. Whereas a child with poor cardiac function from myocarditis, they're typically acidotic. And so they'll have all the signs of acidosis, poor perfusion, elevated bicarb, that kind of thing. And if you happen to do a blood gas, of course, their pH will be low. So in that scenario, think about that as your separator. And when you do fluid resuscitation and you check a BNP, don't be surprised that your BNP increases after your fluid resuscitation because you've stretched the atrium. And so if the BNP goes from say 70 to 90, that just tells you they're not in chronic heart failure and you gave them fluid. It doesn't tell you that, it doesn't mean that the heart functions worse. Does that make sense?
Yes.
Okay. All right.
I have a question about BNP.
Yeah.
So you said it's released from the atria. Is there ever a time where you could have an isolated ventricular abnormality so you wouldn't see a change in the BNP, or are the atria and the ventricles so interconnected that you're always going to see that change?
That's a very good point. So what we're measuring is heart. So we're measuring is overall heart function. And so if the atria. So when we talk about congestive heart failure, BNPs are elevated in congestive heart failure, whether it's related to a cardiomyopathy or related to a large left or right shunt. And typically the BNPs are significantly elevated in patients that have chronic cardiomyopathies. And so because the interplay between the atria and the ventricle are so important cardiac output, that's why you see elevations in BNP. We're not talking, single digits or even tens of digits. We're talking thousands. So if you look back at a patient that we took care of very recently in the ER, I think one of you guys saw the patient with me, is a patient by the name of Crystal Spezial, Speziale. If you look at her labs, what you'll see is this BNP trend, and she was hanging out around 3,000 or 4,000 for a long time. All of a sudden, she came in with inability, with more pulmonary congestion, and her BNP went up to 10,000. So there you go. That would be a good test for her to say that she had chronic elevation in BNP when she was fine, and all of a sudden she, I think, ended up being maybe either COVID or some infection, but her BNP just suddenly jumped up, and that tells us that our congestive heart failure is worsening. So it has to do with the interplay between the atria and the ventricles.
Thank you.
Okay. All right. So when it comes to congestive, when it comes to like when you guys are in the middle of the night, because a lot of times you have to realize, I was a resident not too long ago, and so when you're talking about like order a test and things like that, it's cheaper, it's free to talk to us on the telephone before you order an echocardiogram or anything like that, and but it's very expensive. I'm not saying don't get an echocardiogram, especially, gosh, if a patient's in hypovolemic shock and is in stress, then yes, please order a stat echocardiogram in those patients. But let the cardiologist on call know that it's stat, because just because you order a stat echo, if we don't know it's stat, it's not going to get read stat. That the test is done stat, but until you get an answer from us about what the test results are, it's useless information. Okay. Okay. So if you order a stat echo, please let the cardiologist know that it's a stat echo. All right, that way we can get you a read. And if you're not certain if you want a stat echo, talk to us. Well, we can talk you through it. As I talked to one of the residents the other night, why we didn't need a stat echo, and it had to do with the fact that the blood pressure was normal for age. The child was febrile with the tachycardia, chest X-ray, the heart looked small, and the kid was otherwise in no extremis. Of course, we did the echo at 7 o'clock in the morning, 5 hours later, and all the things that we suspected were right, that the child did not have any cardiac dysfunction, and it was okay to fluid resuscitate. I mean, it was okay to fluid resuscitate based on the presentation, but that confirmed it with that. So you really don't get into too much trouble with fluid resuscitation in patients unless you have significant cardiomyopathy, unless you have significant dilation of the heart. Okay. Okay, all right, so we're about 5 minutes away from 9, I think, looks like. So any other questions, guys? Okay, and most important thing is this, if your x-ray looks like this, and the child is happy and just tachypnic, is comfortably tachypnic, this is gonna be a VSD. If your child's x-ray looks like this, and it has low blood pressure for age, has low capillary refill, then it's a cardiomyopathy to proven otherwise. And that's kind of the take home. That's why I think chest X-rays are very, very useful in terms of cardiac congestive heart failure. Okay? That's probably the single most useful test initially for you guys, especially in the middle of the night when a patient comes in. And also keep in mind that learn how to read a chest X-ray, because hypoventilated chest X-rays, if you have a child where the X-ray is done during the expiratory phase, so the patient's breathing out, the diaphragm is up, so the heart looks bigger, so everything's kind of compressed. And so be mindful of your number of rib spaces, a number of ribs that are visible, and so that tells you whether or not if it's a fake out. Okay, so a lot of times you'll get these X-ray. Oh, it's cardiomegaly on chest X-ray, but then you look at it and the kid's hypoventilated. and then that's not really congestive. Okay. All right. Okie dokie. Okay. All right, guys. I think I'm done for the talk. Any other questions? All right. Have a good day then.
Thank you.
Okay.